My name is Ayush. I'm the CEO of Mindbowser. We have built an operating system for modern clinical care. So whatever you need to do to modernize your clinic and get paid, we have the plumbing for it. We make sure that we work with you and not just for you. So we do work a lot, in collaborative ways so that whatever modern workflows that we are building are not adding more clicks. Together with me is Dr. Shah Khan, a physician who has practiced rural primary care in Northern California at urban academic centers and in rural clinics. He co-founded EnlightetenMed to build a coordinated chronic care model that rural patients actually need. Together, we are going to show you the reimbursement infrastructure that most rural organizations haven't touched yet and what it takes to actually capture it. Because the money exists, CMS has created pathways. Let us show you where the buttons. So with that being said, I'll hand over the reins to Dr. Shah Wickets.
Thank you, Eddie. So to start, I'll introduce myself. I'm an internal medicine doctor. I practice primary care in Mendocino County. It's about 3.5 hours away north of San Francisco. And I guess about 6 weeks ago, my wife got featured in New York Times. So she's also a primary care doctor. We were there for our residency. Drove across the country March 2020, probably the worst time ever to move. And my wife got pregnant while we were there, just as the critical access hospital that we were working at had shut down their OB department. So we had to drive 1.5 hours through the redwoods. It's a pretty drive, not going to do with pregnant wife. And so about a year after that, we decided to move. We moved to Sonoma County, which is just south. And I continued doing telemedicine at the rural health clinic. Works so well that we've expanded to 8 doctors, 4 clinics, in 2 counties. And so along this journey, started working on things like remote patient monitoring, chronic care management, and met IE during the process. He's helping build a care management platform that we use on our patients. So everybody in the room knows this, but I'm just going to review it. So there's 60 million patients in the primary care desert. Decreased access means increased care fragmentation, decreased care continuity, less preventative care, less chronic disease management, or increased burden of chronic disease. And that results in decreased quality, core health outcome, premature death, increased healthcare spending. One of the things that I learned during this process is, in California specifically, so we go from Marin County, which is the other side of this Padolia Bridge, to Lake County, which is 100 miles north. There is a 10-year gap in life expectancy. It goes from 85 to 75. I think that's something that's unacceptable in our country. Practically are living in different countries. Primary care doctors, as everybody knows, have a very tough job. Impossible, some might say. This is from a study published in 2023 in the Journal of Internal Medicine, where they model how much time the primary care doctor would have to spend per day in a 5-day work week to do preventative care, chronic care, acute care, and documentation and inbox management. Now, since this has been published, I think ambient scribed AI scribes have come in, which has helped with the documentation piece. But what they found is team-based care, integrating other clinicians, diabetes educators, helps reduce that time earned. Of course, 26.7 hours a day is an impossible job. And so there's no wonder that primary care doctors are burnt out. Medical students are not attracted to practicing primary care. And so really informs our model, which is to help the folks who are seeing patients there and augment their care. So what is Advanced Primary Care Management? So it's a CMS program that was launched in 2025. Very underutilized. It's meant to pay for the care that happens in between visits. As everybody also knows in this room, that fee-for-service is pretty much a broken system. Primary care is the reimbursement's poor, and no procedures. And so this is meant to buttress primary care reimbursement, and it's based on the complexity of the patient for Medicare patients specifically. So there's 3 different levels. Level 1 is 0, 1 chronic medical conditions. Level 2 is 2 or more chronic medical conditions. And level 3 is 2 or more chronic medical conditions and on Medicaid, meaning they're old, poor, and sick. A departure from prior primary care reimbursement programs is that there's no time tracking required. So very simple math, 20 minutes of time for 1,000 patients is 20,000 minutes. That's basically 2 full FTE to cover that. Otherwise, it's fraught because that may folks dedicated per 1,000 patients. And it's just not really realistic for a clinic to stand something like that up. These are 13 service elements for advanced primary care management. An important distinction is that the CMS will pay for advanced primary care management, even if these are not delivered, even if there's no patient contact, as long as the patient has consented. Now, the patient should have all of these services elements available to them. So 24/7 care access, that's probably the most difficult to operationalize with permissions and the care to me. So our group provides that. And then also an electronic patient-centered care plan that updates as patients go see their specialists. And a lot of what we built together is related to that, is interoperability, being able to pull records then into one place and have a comprehensive view of the patient. So just to start, 1,000 patient panel, and this is for, it says FQHC, but this is across the board. It's reimbursed at FQHCs and RHC is the same at a national rate. So this is looking at 10% for level 1s. So those are patients that really don't have very many needs. It's about $16 that is reimbursed per patient per month. Level 2 are patients, of course, with 2 or more medical conditions. That's about $54. And then 30% in rural areas, as you all well know, there's a high rate of patients who are duly qualified, who are on Medicare and Medicaid. So per month is $69,000 and per year $829,000. Now we're both patient monitoring, which is also a program that's been around since about 2017. Really layers well advanced primary care management. All patients enrolled have chronic medical conditions, diabetes, hypertension, heart failure, conditions that devices monitoring helps with. So that's an additional $25,000 per month, worth about $300K a year. Well, and the rate for patient per month is about $100. Next is behavioral health integration. So, of course, these patients also have depression and anxiety. Some people have bipolar disorder that affects their care. So integrating a psychiatrist into their care, which could be done remotely, yields about 17K extra a month and 211 days a year. And all together, for 1,000 patient panel in a small clinic, you're looking at $1.34 million in additional revenue. without the operational overhead that other chronic care management programs have. Now, CMS specifically designed this program to not having documentation requirements, which kind of throws people for a loop because documentation, as we know, is very important. And so one of the things that we built into the platform is documentation for the best primary care management that's automated and pulls context from the patient and all the things that have been done, and writes it back to the EMR. So their primary care doctor receives the patient, let's say the next week, they got a visit or an interaction, and somebody with our team is able to see exactly what happened, when it happened, and the details. So the number one problem, as we know, is the reimbursement model is not designed for a low volume facility, but like a replaces hospital or rural clinic. Now there are some rules that apply to these facilities that try to buttress the finances, and as we know, many rural hospitals, despite that, are still struggling. The other piece is that the workflow infrastructure doesn't exist. So putting up some of these programs, we were talking about workforce earlier, and I was just chuckling to myself because my wife and I experience every single one of those: housing, child care, OB, labor and delivery, prenatal care, and so workforce and workflow are both a big problem. So being able to plug into a clinic and provide extra help really makes a difference, and allows you to capture that revenue you otherwise wouldn't be able to. And then another problem is how you get doctors to do it, right? So we looked at the number of hours the doctor's got to work. I hope no one's working 24/7, but there are some people who are doing pajama time at 3 a.m. writing notes. So there's a very high cognitive burden, and so programs like remote patient monitoring are, something new that most doctors have not gotten under training. I'd say the majority, or almost nobody, has got training on that. And so the idea of being interrupted in the middle of the day because the patient's got high blood pressure and what to do is not very pure. So there's not buy-in from clinicians. And so our platform solves that problem by taking over that primary care. So it improves the quality of care, and clinicians don't seem to mind if somebody titrates their patient's blood pressure medications as long as they know the patient. And so knowing the patient is about understanding the context of the clinical context. And so with the tools that we have now, we can really capture that context in a way that we never could, meaning that somebody who is coming new to a patient doesn't need to spend, half an hour reviewing their chart to basically understand what's going on. That's already happens before we even interact with the patient. So our platforms is called Health Telematics, and so we operationalize advanced primary care management and remote patient monitoring. So for platform, the patients are enrolled based on their complexity, like I mentioned. There's no time tracking required. And the staffing, like I said, we have digital health navigators, which are essentially remote medical assistants and virtual nurses. And so when patients engage with platform, their mobile application, they're able to get to a health navigator or to a nurse, depending on what sort of issue the patient's having. And, importantly, the finances of the clinic, there's no additional overhead. You'd hire for new folks. And then I mentioned this before, there's lots of health information exchanges out there, not being used as well as they could be. So our platform pulls data, health data for a patient from all the health information exchanges. And so we're able to not only know what's happened in the past, but what's happening in the present. So patients' blood glucose is going up, blood pressure is not controlled, blood pressure medication, their weight is trending up after a heart failure admission, or heart failure discharge, we know is real time. And so, the big idea with advanced primary care management is that a lot of care happens in between visits, and we all know this when we're in healthcare. And the more conditions a patient has, the more complex they are, the more time it takes. So having care in between visits and having the context of a patient available, that's whatever's changed in between visits, or when one of our clinicians interfaces with a patient was really helpful. So our platform is a small screenshot here of the nurse's view. So patients are able to message nurse. AI is able to summarize what the patient is complained of, gather the necessary information, and then that 25-minute nurse call turns into a 3 or 5 minute phone call or message. So oftentimes patients are very comfortable with messaging doctors, and that's actually key. Another part of, it's not captured, you had that graph earlier, which is the inbox, right? How much of the inbox is messages from the patient. And sometimes these questions are very complex, and sometimes I get to a message, that should have been addressed 3 days ago, but no one got to it to get to me. And so with this, patients who have high needs or complex, they're able to get nearly instant access to their care team at any time of the day, and to a clinician if needed. So the nurse would escalate a situation to a physician who's on call and able to either schedule a visit with a patient virtually, or just contact them via text message or phone call. This is here the administrative dashboard, which shows all the finances of advanced primary care management and remote patient monitoring. How many patients are enrolled? How many patients are meeting goals? But because it's a little small. And it's just snap out here, and then you're able to see your outcome mode. Conditions of the advanced primary care management is population health reporting, and so we're able to capture for that patient population all the quality metrics that he scores. And here is the patient mobile app, which has been the most fun to develop. Just imagining patients having an app that they can reach their doctor. And so very simple process. Patients can scan the QR code and enroll themselves, or they can have if their clinician recommends it, they can think about it, or even be consented verbally, and get text message and clinic and bike code. And so again, they're able to find their record in the EMR, and all their data is populated in the app to start, and there's nothing for them to enter. Makes it very easy to enroll. So we did this in 10 weeks, which is, I think, quite remarkable, and tells us a little bit about the time that we live in. And this is where they're working with evaluations team. So it's been a sprint, right? It's been a sprint, and we're at the end of it, and it's really come out nicely. And so we're going to be going live with patients in September although we have trial a few of our organizations who are interested.
Yeah, well, thank you. You have to shop for going to the platform that I think you both have been very proud of. But yeah, because it's been a journey. I think as a clinician, you would remember the skepticism that you had, for getting into the world of technology. Yeah, and I think it took more time to get you started.
Yeah.
Than to execute it.
Yeah, this the thing he started about 2 years ago with remote patient monitoring, and some of the companies that are out there in the hallway, I reached out to them, and there's always this issue of the workflow, integrating it into the local clinical workflow or the local workflow, and so clinicians, I think, they like to have big takeaway. And so oftentimes these companies don't really provide as much personalization. And so our platform can meet the needs of the clinic and be modified. That's where Ayush and his team are helped.
And that's a comment actually, why this was a journey that we were able to achieve in under 10 weeks is because as Mindbowser, we have the Plummet ready for clinical workflows. So this includes all the pathways that are required for interoperability, data storage, security, and so on. So we don't have to worry about those aspects. So that links basically both the speed and solves, the cost issue as well, so less cost, less time, and you are able to get. What I would like to share there is, one number that you shared, 1.3 million. I consider it, like the cost of doing nothing is not zero. The cost of doing nothing is 1.3 million because, that money is there. If done right, you basically participate and, the technology can enable it. As a technologist person, I'd say the technology exists. It's again more of a design problem than technology problem. And that's where we work like closely with clinicians. We were to solve those pathways. One of the things that I always hear from every clinician, like, they don't want to increase their work, basically. So that's the biggest settlement in the mind that, hey, even if I thinking about it, does that increases work over? So what we have made sure is, whenever we are building such systems, we are having clinicians in the room, like Dr. Shah, to collaborate, like multiple times, setting that foundation that what is really required and what needs to go over. Even removing the noise is super important. So that's the idea, and we wanted to share why such story today. We would like to lead you with two pathways here, maybe on the next slide. So one is if you're looking for a ready platform that starts helping you get participated in APCM and CCM, and Telematics, Telematics is the platform, and you can connect with Dr. Shah and we can onboard you quickly. And if you're looking for custom workflows that are more around enabling modernization of your clinics and custom journeys that you want to do for yourself, you can scan a QR code for me and you can connect with me. So yeah, you just want to make sure that you take a step at it, either. That's because you're choosing one person. Okay. So thank you so much. Bye.